Dear friends, today we will talk about anterior ischemic optic neuropathy. This is a part of our retina series, which is a part of, again, ophthalmology grand rounds that we are conducting. So today we will look at analysis of a 78-year-old male patient who came with sudden loss of vision in the left eye. We'll examine his clinical features, come to a proper diagnosis, look at how we will reach a diagnosis and plan management of this patient. The objective today would be first the presentation and then the clinical examination and diagnosis. We will then understand more about anterior ischemic optic neuropathy and look at management options. So this is a 78-year-old male patient who comes from Kerala with a middle class background with sudden loss of vision in the left eye for 2 weeks. According to the patient's perspective, he suddenly lost his vision in the left eye 2 weeks back and he is not able to recognize people or cannot move around, and he is not seeing the inferior part of the whole area. This is his complaint. Moving on, his onset was sudden and it was painless. There was a progressive deterioration of vision over the next 2 weeks. There was a significant temporal headache that he complained, and there was no movement pain. So pain on eye movements was not there. He had visited another hospital and he was started on systemic steroids. He was completely unable to recognize faces, read or write, or even walk around properly in the house because he was stumbling upon objects. So let's just analyze the history here. So here is a patient, an older patient, about 78 years old, who suddenly complains of decrease of vision. What could be the problems? Right from anterior, whenever we are asked about a decrease of vision and looking at causes or anything like that, we should be always looking at anterior segment to posterior segment, right from the cornea to the optic nerve. So what call could be? There's a sudden loss of vision, painless. So you can most often remove all the corneal pathologies, even the anterior segment pathologies, unless there's a spontaneous hyphema or something like that. Then coming on to the vitreous, there could be a vitreous hemorrhage, or there could be a central retinal artery occlusion, a retinal vein occlusion, age-related macular degeneration, diabetic retinopathy with bleed, optic neuropathies. These are some of the sudden loss of vision. So it progressed over 2 weeks. Doesn't tell us a lot of things. Progressing over 2 weeks can be even a retinal vein occlusion, even a bleed inside the eye, even all those things can progress over 2 weeks. Temporal headache. Temporal headache is something which is very important, and especially in older age, that may signify an ischemic optic neuropathy, especially the arteritic AION variety. Now, he visited another hospital and he was started on systemic steroids, which completely meant that there's something inflammatory going on. Moving on, in this patient, what are the negative histories that you will take? There's no redness, pain, watering, photophobia, foreign body sensations, which completely removes all the anterior segment problems, the cornea, conjunctiva, anterior, the anterior chamber. All those inflammatory infective pathologies are ruled out. No pain on extraocular movements. Here again, we are looking at optic neuritis as one reason. He's a 78-year-old, which means optic neuritis is not very common in that age group. Even then, there's no pain in extraocular muscle movements. There is no flashes and floaters, which removes PVD, retinal tears, retinal detachment, vitreous hemorrhage secondary to that. All that is negated. No double vision, which means that there is no acute diplopia or anything like that happening. We have to also look at, in this particular person with 78 years old with loss of vision, you should always ask for history of jaw claudication. You should always ask for history of back pains, etc., scalp tenderness, etc. Now we went to the past ocular history of this person. He had a similar episode of loss of vision in the right eye approximately 5 years back. The treatment details were unknown, but there was no recovery in vision. There was no surgical intervention in either eye, no laser, no trauma, no surgery. So let's look at what are the causes of sequential loss of vision in both eyes. This is a case of an older person, sudden loss of vision, one eye loss of vision about 5 years back, and the next eye coming to a loss of vision now. What could it be? It could be, well, diabetic retinopathy, it could be retinal vein occlusion, it could be retinal artery occlusion, it could be anterior ischemic optic neuropathy, it could be vitreous hemorrhage, it could be an age-related macular degeneration with a bleed. So all these are possibilities here. But one thing which stands out is temporal, pain, headache on the temporal side, and number two, difficulty in vision in the inferior half of his field. These two were giveaways in this patient. But a retinal vein occlusion can have an inferior field loss. Even an AMD with a bleed superiorly can have an inferior field loss. Any bleed superiorly can have an inferior field loss. So all those are other differential diagnoses though. So let's move on. What is his systemic histories? He's a type 2 diabetes mellitus patient who is on insulin with systemic hypertension also with 15 years and dyslipidemia and also a coronary artery disease. So all the major problems including diabetes, hypertension, dyslipidemia and coronary artery disease are there in this 78-year-old individual who may predispose to all the conditions that we mentioned before, including diabetic retinopathy, including retinal vein occlusion or arterial occlusion, including age-related macular degeneration and AION. So all these are possible with these systemic comorbidities. Personal history was unremarkable. Family history was unremarkable. His general physical examination, he was conscious, oriented, and cooperative, moderately built and nourished. His blood pressure was 130 by 85, which is fairly normal, controlled hypertension. He's on treatment. And other systemic examinations was also unremarkable. Cardiovascular, respiratory, and per-abdominal examination was normal. His facial and head alignment was normal. The ocular alignment was orthotropic. There was Hirschberg test was normal. The extraocular muscle movements were complete. The full range of movements, no limitation, no pain. Anterior segment examination again was like this. Visual acuity was hand movements, PL plus and PR accurate in both eyes. He was given a near vision aid of +3 without any visual improvement. The pressure measured in both eyes using non-contact tonometry was 16 millimeters and 17 millimeters. And so the visual acuity in both eyes is hand movements, PL plus, PR accurate. Orbits, eyelids, eyelashes, conjunctiva, everything was normal. Cornea was again normal, no KPs, no guttae. Anterior chamber was normal in Van Herijk's grade 3, quiet, no cells, no flare. Iris was normal, normal pattern. Pupil was 2 millimeters in both eyes, and reaction was sluggish. There was almost no reaction in both eyes. There was no relative afferent pupillary defect also. The lens showed grade 2 to 3 nuclear sclerosis in both eyes. Anterior vitreous was normal. And coming to the dilated retinal examination, media was hazy because of the grade 2 to 3 nuclear sclerosis and cataract. It limited the detailed view or very, very specific view, but optic nerve in the right eye showed pallor. It indicates chronic optic atrophy. Macula appeared normal with no obvious edema or exudates. Retinal vessels arising from the discs appear a little smaller in caliber. It was much smaller. The AV ratio was normal, but there was attenuated blood vessels. There was no hemorrhages, no cotton wool spots. Peripheral retina was normal without obvious abnormalities. Whereas the left eye, we had a disc edema. The margins were hazy, especially inferiorly, but it had an associated pallor. Blurring of disc margins was there almost all 360 degrees. Elevated disc margins were there. Significant elevation was there inferiorly and superiorly. There was a halo around the optic nerve. There was a dull foveal reflex with a few hard exudates superior to the macula and few superficial scattered hemorrhages were there. There was no evidence of any vascular block, vasculitis, or any inflammatory exudates anywhere. Peripheral retina was also normal. What is our provisional diagnosis here? There is cataract with nuclear sclerosis. There is an associated diabetic retinopathy, most probably moderate to severe diabetic retinopathy with hard exudates, which means there may be a clinically significant macular edema as well. Right eye has optic atrophy and left eye has a pallid disc edema. So what is our ocular diagnosis? We would diagnose this as a left eye anterior ischemic optic neuropathy, likely to be arteritic, right eye optic atrophy, probably secondary to an old AION, both eyes immature senile cataract, and both eyes diabetic retinopathy. This would be our ophthalmic diagnosis. And the systemic conditions that we have to also add would be a type 2 diabetes mellitus on 26 years, systemic hypertension, dyslipidemia, and coronary artery disease. So when you are looking at an optic nerve pathology, what are the differential diagnoses that we keep in mind? Inflammatory, could be glaucoma, that would be the most common. It could be ischemic, it could be hereditary, nutritional or toxic, and traumatic. So let's look at each of them. Glaucoma being the most common, we have to look at one specific thing called cupping, and also the intraocular pressure, the angles, the corneal thickness, the visual fields. All this will give us a clue towards glaucoma and the types of glaucoma, including primary open angle or angle closure or even secondary glaucomas. We are looking at a 78-year-old person, so most probably if it is a glaucoma which is now we are diagnosing, it could be an open angle glaucoma rather than an angle closure which may present a little earlier. Looking at inflammatory diseases, which is also very common, one thing would be a demyelinating optic neuritis. We could have an inflammation including sarcoidosis, SLE, polyarteritis nodosa, etc., or even an autoimmune optic neuritis secondary to some other inflammatory pathology within the eye. We will come to how to differentiate between them soon. Ischemic, yes, we have arteritic and non-arteritic AION, and also posterior ischemic optic neuropathy, which is again another entity which we will talk about. Hereditary, we have a Leber's hereditary optic atrophy, dominant optic atrophy, the Behr and the Kerr, and the mitochondrial diseases. Nutritional deficiency causing optic neuropathies may be secondary to vitamin B12 deficiency, and some drugs like ethambutol or methanol poisoning can also lead to these. Traumatic optic neuropathies, orbital tumors, intracranial mass lesions, these are again another group of lesions secondary to this to cause optic neuropathy. Now, what are the types of ischemic optic neuropathy? As I said, we have two types of anterior ischemic optic neuropathy, the arteritic variety and the non-arteritic variety. And yes, we have the posterior ischemic optic neuropathy, the PION. These are the different types of optic neuropathies. Again, PION can also be arteritic and non-arteritic. Maybe it could be a surgical PION as well. Now, what is the pathophysiology of anterior ischemic optic neuropathy? Basically, there will be reduction of blood supply to the posterior ciliary artery to the anterior part of the optic nerve, primarily affecting the prelaminar and the laminar regions. All right. So central retinal artery here is most probably normal. So the key vascular supply are short posterior ciliary arteries, which is the primary supply to the optic nerve head. Circle of Zinhaler, the arterial circle formed by the branches of this short posterior ciliary artery and the central retinal artery. These are the key vascular supply to this region. The watershed zones between vascular territories are always very critical and vulnerable to ischemia, especially in the presence of hypoperfusion or vascular compromise. So this is the pathophysiology of anterior ischemic optic neuropathy, in which the vascular element which supplies one segment of the optic nerve, either the superior or the inferior, can get affected, and that causes sudden loss of vision. And what would happen to the optic nerve? Because of the block, there is going to be edema. And because of the block again, there is going to be pallor. So pallor plus disc edema is characteristic of anterior ischemic optic neuropathy. Now let's just try to compare and contrast the non-arteritic AION and the arteritic AION. Typical age of a non-arteritic AION is about 60 years, whereas that of an arteritic AION is a little older, 70 plus, 80. Sex predilection is almost the same in NAION, whereas in an arteritic AION, women are a little more predisposed. Associated conditions in a non-arteritic AION would be diabetes, hypertension, coronary artery disease, cholesterolemia, etc. Whereas in arteritic AION, we are having giant cell arteritis, temporal arteritis. So if you have a diagnosis of temporal arteritis, it's very highly likely to be an arteritic AION. Visual acuity loss in an NAION is lesser. From 6/6, it can be somewhere around 6/60 or even lesser. Whereas in an arteritic AION, the loss of vision is going to be very, very huge. It's going to be less than 6/60 in majority of patients. And it may be even PL plus, PL minus also in a lot of patients. There could be a small crowded cup with hyperemic edema in a non-arteritic AION, whereas in arteritic AION, it's going to be pallid disc edema, which is very, very remarkable. ESR is going to be lower in non-arteritic, whereas ESR is a giveaway, near about 100, more than 70 definitely in arteritic AION. So much so that in the presence of an AION, the first investigation that anybody would want to do is an ESR. If the ESR is near 100, you are looking at arteritic, immediately you are going to give them treatment for that. CRP is also elevated in arteritic AION, platelet count is often elevated in arteritic AION. Again, prognosis wise, arteritic AION prognosis is poor, it rarely improves. And fellow eye involvement, which is very important, it occurs in more than 50 to 90% of people in different studies. You require immediate treatment, not to save this eye, but to prevent the occurrence of AION in the other eye. Now let us come to our case. This guy had 78 years old. He had diabetes, hypertension, dyslipidemia and coronary artery disease, which are all predisposing factors for NAION, but having a temporal arteritis and having a complete loss of vision in the other eye with optic atrophy with absolutely no recovery and a pallid disc edema in this eye and so much low vision with temporal headache gives away a probable diagnosis of arteritic AION. Now we will look at clinical characteristics. Basically age is more than 40 to 60, as I said, in NAION, and there will be a sudden loss of vision with color vision defect. Altitudinal field defect is often seen. Relative afferent pupillary defect may be there if there is unilateral pathology. Optic disc edema is there in acute phase, but in a very chronic phase, the disc edema completely disappears. Histopathology wise, you have giant cell arteritis, and how do you prove giant cell arteritis? One thing is by doing a temporal artery echo or ultrasound and finding out which part of the temporal artery is showing a pathology. And that part which is showing the block, probably you could do a temporal artery biopsy to establish the diagnosis of giant cell arteritis. There is going to be granulomatous inflammation in the small and the medium-sized vessels with full thickness infiltration with inflammatory cells. There could be lymphocytes, plasmacytes, macrophages, multinucleated giant cells, and this could very well be seen in giant cell arteritis as well as in some of the other conditions like SLE, polyarteritis nodosa, rheumatoid arthritis, which is quite rare. So let's look at the clinical features of arteritic AION completely. Headache may be often severe, and it is localized to one particular area, usually the temporal region. Scalp tenderness, when you touch, it is going to be very, very tender. And palpable temporal artery may be there, which is non-pulsatile. Proximal muscle and joint pains and aches like polymyalgia rheumatica may be seen. There could be anorexia, weight loss, low-grade fever, jaw claudication, and cranial nerve palsies. Ocular features may include severe visual loss, rapidly progressive within 1 or 2 days, and fellow eye involvement in up to 95% within days if not treated. Ocular examination findings may include, anterior segment which is fairly normal, but there could be chalky white pale optic nerve versus a hyperemic optic nerve in an AION. Cotton wool spots may be seen near the optic nerve, and probably there could be celioretinal artery occlusion in about 20% of the cases. Angiographically, you may have a delayed disc filling and a delayed choroidal filling also. So these two, when they are together, then you are looking at an arteritic AION. So cup would be usually normal, unlike in a non-arteritic AION where the cup is going to be crowded. There will be more severe disc edema as compared to the NAION, and there will be more profound vision loss as compared to NAION. Now, what are the investigations that we will do? ESR, usually it's more than 70, may reach 120, 130, etc. CRP may also be very high. Combined ESR plus CRP high has a 97% chance of specification in this particular context. Additional tests may include complete blood count, color Doppler of the temporal arteries, etc. And finally, temporal artery biopsy is a gold standard. How do we manage it? Emergency treatment is about initiation of very high dose pulse corticosteroid therapy. Especially if you have an AION in one eye, the other eye is normal, the ESR is high, he's an old patient, there's some symptoms of temporal pain or temporal artery which is non-pulsatile, thick cord-like, scalp tenderness, anything like that. Immediately initiate the patient on IV pulse methylprednisolone. It's critical to prevent the occurrence of this particular problem in the other eye. So usually we give methylprednisolone 1 gram for 3 to 5 days. It's usually administered either very slowly or in divided doses. And if he's a diabetic, we have to take care to control his sugar status as well as his blood pressure status. Then we will taper him with the oral steroids, about 80 milligram to 100 milligram per day depending on his weight, 1 to 1.5 milligram per kilogram. And then we will taper gradually and we will look at ESR, CRP as markers to taper the dose. The maintenance dose of about 5 to 15 milligram daily may be required and may require a long-term therapy or steroid sparing agents. So tocilizumab, which is an interleukin-6 inhibitor, it blocks IL-6, and IL-6, as you know, is an inflammatory cytokine. It was FDA approved in 2017 for the treatment of giant cell arteritis. It's administered on a monthly intravenous infusion or weekly subcutaneous infusion. Other steroid sparing agents like methotrexate, azathioprine, cyclophosphamide can also be used. Now let's look at NAION, which is again a younger brother of arteritic AION. Here, most of the critical things we have already talked about: diabetes, hypertension, hypercholesterolemia, coronary artery disease, all those are the problems. In a 40 to 60-year-old person, less severe, vision loss will be acute, there will be a hyperemic disc edema, there will be a crowded disc, and there's going to be an altitudinal field defect. Many patients do recover in vision. Disc appearance is in stark contrast with arteritic AION. Hypertension, ischemic heart disease, hyperlipidemia, carotid disease, diabetes, hyperhomocystinemia, metabolic syndrome, nocturnal arterial hypotension, sleep apnea, and medications like sildenafil, amiodarone, and hypercoagulable states are all predisposing factors for non-arteritic AION. Non-arteritic AION you would treat by basically what we will do is you can just control the systemic factors, and many of these patients may come back in visual acuity. Some of the differential diagnoses that we have to always keep in mind is one is Foster-Kennedy syndrome, in which one eye is having optic atrophy and the other eye is having disc edema, and there is usually brain pathology which is seen in Foster-Kennedy syndrome. Ipsilateral optic atrophy here is to direct compression by the intracranial mass, and the contralateral disc edema secondary to pressure effects. Typically occurs in frontal lobe tumors like meningioma or glioma, and also some other lesions. Optic neuritis, there is sudden decrease of vision, but there is going to be pain on eye movements, and more central visual acuity loss will be there rather than altitudinal visual acuity. And infiltrative optic neuropathies like lymphoma, leukemia, a blood picture can immediately come to our rescue. Compressive optic neuropathies, again, you will have lesions on the visual tract, anterior orbital lesions, etc. And one other differential diagnosis that we have to consider is diabetic papillopathy, in which there is disc edema in these diabetic patients, and usually the vision is not significantly affected. It's typically bilateral, and recovery of vision is usual. Neuroimaging is significantly required in all these patients to rule out any brain pathologies. Even though we may clinically make a diagnosis of arteritic or non-arteritic AION, it is often required to have a neuroimaging to complete the diagnosis. So we need to do vascular risk assessment, probably sleep apnea screening, thrombophilia workup, carotid Doppler studies to complete the investigations. Thank you very much.